I'd like to welcome John for coming along and saying a few words to open today's event. John has been our mayor since 2015, and he has had a long interest in health matters, and I'll let him elaborate on that if he so wishes.
Okay, I'm really grateful, Randall, and can I first of all thank HealthWatch and Randall Smith, who's an old mate of mine, as well as being a very dedicated volunteer with HealthWatch in Tower Hamlets, and they do good work, part of the glue that helps keep our community together and help keep the council and our health providers on their toes as well. I'm not going to say a massive amount, except that, Randall says I go back away. So before I was mayor for a period, I was director of a national organisation within my party called the Socialist Health Association, which is a venerable organisation that was involved in setting up the health service back in the 1940s,
Hello,
which was before my time. What I really wanted to say that as mayor of town, we really welcome Michael Marmot coming in and gracing us with his presence here in this presentation. Tower Hamlets is a place where a lot of our experience is rooted in tackling the problems of ill health and poverty and social exclusion, and all those things fit together. It's not just about health, it's about social exclusion, it's about poverty, it's about people not having the tools to help themselves or not having the support to help them in their lives. And the public health journey may have started 150 years ago or so, with people talking about basic sanitation, decent housing, dignity in work, dignity in childbirth, all of those things. But the inequalities continue, and I'm sure that others will make the points about the inequality gradient as you travel eastwards down the railway line through London from the centre. And those facts are still very, very stark with us, with life expectancy being low and healthy life expectancy being one of the lowest in the country in Tower Hamlets. And so the more insights we have and the more awareness we have of what we can do to try and tackle these evils in our midst, the better. Really appreciate the work that others are doing. The council needs as a sort of ringleader to help pull this piece together as well. But let's get on with it, Randall, and let's hear from your guest speaker. I have to apologise because I have to do some other stuff related to COVID actually, and our management of the pandemic. So I'll be briefly attending and then leaving this session. But thank you very much. I think my lead member, Councillor Rachel Blake, is on this call as well, and she leads on health and adult services and is very actively involved in this work as well. So thank you.
Thanks, John, and thank you for coming. We will, of course, be putting a report together from this, and also bringing our report that Raluca will be delivering later to the Health and Wellbeing Board, and feeding that in through the whole process. But as John says, let's move on quickly to our keynote speaker for today, which I'm sure is the main attraction for all of you, Sir Michael Marmot. Sir Michael, to say we are thrilled to have you addressing a HealthWatch Tower Hamlets audience would be an immense understatement, and thank you for agreeing to do so. For those of you who've not come across Sir Michael Marmot's work, I will only say a few words now, and I would encourage you to take a look at his catalogue of publications, which are really very, very important to all we do. Sir Michael is Professor of Epidemiology at University College London and is known for his extensive and groundbreaking work on health inequalities and the wider social determinants of health. He chaired the World Health Organization's Commission on the Social Determinants of Health, and following that, at the request of the British government, undertook the Strategic Review of Health Inequalities, publishing in February 2010, A Fair Society, Healthy Lives. And this past February, the Marmot Review 10 years on. Those two documents together can really give you a strong picture of what the inequalities mean, how they impact our wider society, and how we have progressed or not. And whether you're in the fields of health or other areas of social policy, I really do very much urge you to take note of Sir Michael's findings and insights to grasp the interrelated aspects of inequality in housing and employment and health and so on. but it's not for me to speak about these, but to welcome Sir Michael and ask him to speak to us now. Sir Michael.
Thank you. And it's a pleasure, he said, after a moment of anxiety, to make sure his slides would come up. Tower Hamlets is part of the planet. And my own perspective varies from the local, such as Tower Hamlets, or work we're doing with Gateshead, Greater Manchester, Chester, Merseyside, to thinking in a more global way. And I want to start with putting, particularly in the light of the COVID-19 pandemic, putting what's going on in England in the global context. Just 12 months ago, almost to the day, on the 1st of October, I had chaired the commission of the Pan American Health Organization on equity and health inequalities in the Americas. And we published our final report, and we called it Just Societies, Health Equity and Dignified Lives. We wanted throughout the Americas, North, Central, South America, the Caribbean, to bring together the work on health equity. We began our report with a quote from Nelson Mandela: "Overcoming poverty is not a gesture of charity. It is an act of justice. It's the protection of fundamental human rights, the right to dignity and a decent life." And this was the conceptual framework of our global commission. And I'd like to think that it applies to what we're doing nationally and in local areas such as Tower Hamlets. We start with structural drivers, political, social, cultural, and economic structures, and they're all about us now. The natural environment, land and climate change, and ongoing colonialism and structural racism, highly relevant to something I will say in a moment. And then conditions of daily life, early life and education, working life, older people, income and social protection, violence, environment and housing, and health systems. And we had recommendations for each of those and each of these 7, and then 2 recommendations on taking action, governance and human rights. And we took the approach of intersectionality, looking at social and economic inequities, gender, sexuality, ethnicity, disability, and migration. And the outcome was health equity and a dignified life. The idea that was animating us is if you get the conditions right for people to lead dignified lives, those will be the same set of conditions that will relate to health equity. Let's put the COVID-19 pandemic in global perspective. The UNDP, the Development Programme, Human Development Report, published a special report a couple of weeks ago on COVID-19. If you look globally, there's transport injuries, deaths, HIV/AIDS, self-harm, malaria, which is huge, and there's COVID-19, actual deaths. So you can see the dramatic impact it's had in the short term. The Human Development Report looks at development. It has a Human Development Index, which has 3 components: health, life expectancy, education, and income, gross national income per person, adjusting for purchasing power. And this is the global Human Development Index from 1990 on. And it was increasing, sometimes a bit less, sometimes a bit more, increasing every year. The global financial crisis, 2008, 2009, had an impact on human development globally, but it was still increasing. And this is the predicted effect of the pandemic in 2020 on global human development. So yes, we're suffering in Britain, of course we are, but the planet is suffering as well. Let me show you a different kind of shock. This is Hurricane Maria in Puerto Rico, and excess deaths related to the hurricane in the lowest socioeconomic group, the medium, and the highest socioeconomic group. Any major excess shock, like a hurricane, like a pandemic, is likely to increase inequalities. And I've been saying about the COVID-19 pandemic from the beginning that it will expose the underlying inequalities in society and amplify them. It's like a hurricane. The opening line of my book, The Health Gap, if you haven't read it, please do, was why treat people and send them back to the conditions that made them sick. We've become very aware with the COVID-19 pandemic of how vital the health care system is. That goes without saying. I don't want to talk today about the health care system, but about the conditions that make people sick. As you heard in the introduction, I produced on February the 25th, 2020, just before the pandemic crashed upon us, Health Equity in England, the Marmot Review, 10 years on. Just to summarize, I chaired the WHO Commission on Social Determinants of Health, and we reported in 2008. And then the British government said, how could we apply the findings and recommendations of your global commission to one country, England? And I produced the Marmot Review in 2010 on health inequalities in England. And we took a look back. What's happened in the last 10 years? It said for a moment, I've been muted, but I take it you can hear me now. So we wanted to look at what had happened over the last 10 years and what we could learn from it. And my summary was, we've lost a decade, and it shows. Here's the evidence for that statement. Life expectancy was improving about 1 year every 4 years for women and for men. I've taken this back to 1980. I could take it back to 1890. And life expectancy was improving about 1 year every 4 years. And this long-term trend ground to a halt in 2010-11. A marked slowdown, and the improvement just about, as I said, ground to a halt. One of the questions that got raised was, well, it can't go on improving forever. Surely the improvement in life expectancy has to slow sometime. Have we just reached peak life expectancy? And the answer is no, we haven't. Estonia, Norway, Slovakia, Hungary, Denmark, Belgium, Austria, Japan, all of these countries had more rapid improvement in life expectancy than we did. There's the UK. We had the slowest rate of improvement in life expectancy of all of these major countries, except Iceland and the United States. Let me jump ahead to the pandemic. The Office for National Statistics, this is the Economist's graph, but the ONS published excess mortality. Excess mortality gets round the problem of international comparisons of COVID-19 deaths because of differences in the way cause of death is assigned. So the excess mortality is the number of deaths that occurred in 2020 over and above what would have been predicted on the basis of the previous 5 years. And the excess deaths in England were higher than in Scotland and higher than in any other European country. So put these two things together. Before the pandemic crashed, our health was poor. The slowdown in improvement was more marked than in virtually any other country except Iceland and the US. And then it came to our response to the pandemic, and the excess mortality was higher than in any other European country, and including the United States. Is there a link between these two? Maybe we're learning something about the society. I've been arguing for a very long time that the health of the population tells us a great deal about how well the society is functioning. If health has not been improving, society has not been improving. And health inequalities tells us a great deal about inequalities in society. So let's look at inequalities. The social gradient, most deprived, least deprived areas of England. And it's not only that people living in the most deprived areas have shortest life expectancy, but it's a gradient. The less the deprivation, the longer the life expectancy. The gap between least and most deprived for men was 9.5 years, for women 7.7 years. And that gap's been getting bigger. The gradient's been getting steeper. The inequalities have increased. And then there are regional differences. Let's look at women in the least deprived decile. The regional differences are quite small. And life expectancy is going up, not markedly, but going up in virtually every region for women in the least deprived decile. So if you're in the least deprived decile, it doesn't matter too much which region of the country you're in. But if we look at the most deprived decile, there are huge regional differences. Life expectancy for women in the poorest 10% is going up in London and going down in virtually every other region. So the regional inequalities are getting bigger. So just to summarize then, before the pandemic crashed, we had slowdown in life expectancy improvement, marked slowdown, increase in inequalities, and health for the poorest women was getting worse outside London. And then we look at COVID-19. The gray is all deaths, the social gradient for all causes, and the blue is the social gradient for COVID-19 deaths. I'll come back to this excess in a moment. But the fact that the two lines are fairly parallel, the social gradients fairly parallel, means that the causes of inequalities in health more generally overlap with the causes of inequalities in COVID-19. In other words, the pandemic makes it even more important to take action on inequalities in health. This excess down the bottom is very likely related to employment in frontline occupations, to living in overcrowded conditions, multi-generational households, and to the presence of pre-existing conditions that increase risk: chronic obstructive pulmonary disease, diabetes, obesity, cardiovascular disease. And we see a similar gradient in Scotland for all-cause mortality and for COVID-19 mortality. The death rate from all causes is 1.9 times higher in the most deprived area compared with the least, and 2.3 times higher. So exactly the same picture, very similar gradient with a slight excess for COVID-19 down the bottom. And then we come to ethnicity. Let's look at Black British. This is the Office for National Statistics report. You can see the huge excess in COVID-19 mortality. The blue here is what ONS calls fully adjusted, much of which is deprivation. So a big part of the excess in women who are classified as Black British, a big part of that excess can be attributed to deprivation. And in men, a bit more than half the excess attributed to deprivation. Bangladeshi or Pakistani, most of the excess in women is linked to deprivation, and 2/3 to 3/4 of the excess in men. When these data were published, senior figures in the government were asked, what do you think about this? And they were terribly concerned. And they said, it's very important for people of color to wash their hands and practice social distancing. And I was asked on the BBC, what do you think? And I said, good advice, but we have to deal with structural racism. Yeah, but what should we be doing tomorrow? Tomorrow, we should be dealing with structural racism. Yes, social distancing is important, but so is discrimination. In my 2010 review, I had 6 domains of recommendations. Equity from the start, give every child the best start in life. Education and lifelong learning. Fair employment and good work for all. A healthy standard of living for all. Healthy and sustainable places and communities. And taking a social determinants approach to prevention. The government that was elected in 2010, the Conservative-led coalition government, presented austerity to us as if it was a moral imperative, that we had no alternative but to reduce public expenditure. And they did it, by golly. In 2009-10, public expenditure was 42% of GDP, and it was brought down by 2018-19, the 42% had become 35%. And it was done in a most regressive way. This is spending by local authority, council spending per person. And for the least deprived 20% of areas, the grey is total local authority spending per person. In the least deprived 20% of areas, it went down by 16%. And then the more deprived the area, the greater the reduction. In the most deprived areas, the spending by local authority went down by 32% per person. In other words, the greater the need, the greater the reduction. In Liverpool, it was greater than 40% reduction. Wow. And the supposed reason for this was to put the economy on a good footing, to get economic growth. Well, it didn't work. This is wage growth in the UK, 2007 to 2018. Greece had a negative wage growth, Mexico, and the UK was third from the bottom of all of these rich countries. And all of these other countries had faster wage growth. They didn't impose the same austerity that we did. Early life. This is children living in poverty. Poverty is defined as less than 60% median income. Before housing costs, 18% of children were in poverty. After housing costs, it was 27%. So housing is a very important cause of poverty, the lack of affordability. In London, this gap was something like 17% of children were in poverty in London before housing costs, 37% after housing costs because of the cost of housing in London. But so this 27% went up to 30% by 2017-18. Child poverty was rising. Let's look at children growing up in a household headed by a lone parent not working. In 2010, 61% of children were in poverty. And by 2017-18, that had gone up to 70% of children growing up in a household headed by a lone parent not working. 70% were in poverty. Work was supposed to be the way out of poverty. So let's look at a lone parent in full-time work. 18% of children were in poverty in 2010-11, and that went up to 30%. This is fundamental. Children growing up in poverty have less good measures of early child development. Children who have less good measures of early child development do less well in school. Children who do less well in school are less likely to graduate with qualifications. People without qualifications get less good jobs, lower pay, live in worse conditions, and have worse health. So health inequalities start from the beginning of life, and they relate to the level of children in poverty. These are changes that the Chancellor of the Exchequer made to the tax and benefit system between May 2015 and June 2017. The green is working age families with children, and it's deciles of income. As a result of the Chancellor's changes to the tax and benefit system, people in the bottom decile will lose 15% of their income. People in the second bottom decile of income will lose 12% of their income, and so on. The richer the family, the less the reduction. The Chancellor's apparent aim was to make poor people poorer. Now let's look at what happened during lockdown. This is food insecurity. Pre-COVID-19, during COVID-19, it doubled. And then food insecurity due to supply issues. These are data from the Food Foundation. During lockdown, 2 million children are food insecure. Lockdown and learning. One of the effects, predictable effects of closing the schools was to increase the educational divide. Teachers were asked to rank their pupils as to how far behind they were. In the schools in the least deprived areas, they said 3% of their children were not behind at all, 24% fell 1 month behind, 32% 2 months behind. In the most deprived schools, 11% of children were assessed as being 6 months or more behind, 18% were 5 months behind, 24%. So it's spreading out. The educational divide is increasing as a result of lockdown. It is, of course, vital to have the schools open, but we didn't put in place the mechanisms to make that safe. Let me go back to the global perspective. The UN, United Nations Development Programme, classifies countries into low human development, medium, high, and very high, based on those three measures that I mentioned: health, education, and income. And this is the percent of primary school age children who are effectively out of school before the COVID-19 closures and after. So in low development countries, 86% of children, primary school age children, are effectively out of school. And even in the very high, it's 20% of children effectively, primary school age children, effectively out of school. Now, let's look at the difference that a simple intervention could make. So this is the effective out-of-school rate globally from 1970 to 2019. It's under 10%. More than 90% of primary school-age children were effectively in school. The blue here is the effect of the pandemic. The red is the effective out-of-school rate if there was no internet access. And the black here is the effective out-of-school rate predicted if you could close the internet gap within a human development group. In other words, let's take the low human development group. You look at the groups that have the highest internet access and the groups that have the least, close that gap. And you could just about get rid of the effective out-of-school bump due to the pandemic. A very simple intervention. Now think about Tower Hamlets. Same issue. Are children effectively plugged in to the internet? Do they have access? And again, globally, the ability of people to come up with emergency funds, low human development, medium, high, and very high, by wealth quintile. So we're a very high human development country. Of course, people in the top wealth quintile, nearly 90% are able to come up with emergency funds, but they don't need it because they were not affected very much by the pandemic and by lockdown. People in the bottom wealth quintile were highly affected because they lost their jobs or they were on a furlough scheme. And nearly half had no ability to come up with emergency funds. And the higher the human development, the greater the ability to spend to offset the effects of closures, direct spending and loans and guarantees. I was intrigued with the publication of the Social Progress Index, I think 3 weeks ago now. And I compared, the Social Progress Index has 16 indicators, and I chose a couple, and I compared 3 countries: Germany, that's handled the pandemic very well, the USA, that's handled it very badly, and Brazil, which has been a catastrophe. So Germany, this Social Progress Index of inclusiveness, which is high in Germany, up a bit, down a bit, essentially no change. The US, which was close to the German level, 2011, had been declining a bit. And then between 2016 and 2017, I can't think what might have happened in the US in November 2016 that could account for this, but it declined further. And a similar catastrophe, and Trump in the tropics, in Brazil, with the decline. And another index of social progress, personal safety, high in Germany, and it remained high. In the US, catastrophic drop between 2016 and 2017. And Brazil, it was always much lower, but it's been declining. Now, this is not even correlation, let alone causation. It's sheer speculation. But one country that handled the pandemic well, Germany, has good measures on social progress. 2 countries that handled the pandemic very badly, the US and Brazil, have very poor measures on social progress. And you're asking, where is the UK? It's between the US and Germany. And then there's the environment. PM10 as a measure of air pollution. The most deprived quintile, least deprived quintile. Much more exposure in London for the most deprived than the least deprived. In Liverpool, in Birmingham, in Bristol, in Leeds, and Sheffield. In my 2020 report, I argued that we have to bring the climate change and the health equity agendas together. We said, for example, that 100% of new housing should be carbon neutral by 2030 and should be affordable or in the social housing sector, and aim for net zero greenhouse gas emissions. Let me finish with this. As we think about emerging from the pandemic, of building back better, I would like us to think about a well-being approach, which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. Where might I have got that quote from? Economist and philosopher Amartya Sen? No, it was the New Zealand Ministry of Finance put in 2019 at the heart of their policies, a well-being approach which can be described as enabling people to have the capabilities they need to live lives of purpose, balance, and meaning for them. I would like to think that that should be our aim as we emerge from the pandemic. And the recommendations in my Marmot 2020 report provide the solid, practical actions that need to be taken to achieve this. Thank you.
Thank you. That was mixed emotions, I guess I get from that. There's some things there that are grim truth, but also a lot of hope and guidance on where we need to take things forward. And it's also really topical, given that just in the last couple of days, the NHS Confederation has published a new report on the new direction for health and social care. And it identifies tackling health inequalities as one of the priorities. And one of the key recommendations is that co-production is essential in improving services and preventative approaches as well. And I'm just going to steal a question here. And I ask, what role do you think the end user of health and social care services needs to play in addressing those inequalities, and how can we ensure their voice is heard?
Well, what we've been saying to the health services, I'll come to the care in a moment, what we've been saying to the health services is that, of course, we need universal access to high quality care. But in addition, the health care system can be active in addressing the social determinants of health. And we identified 5 areas: education and training, seeing the patient in broader perspective, the health system itself, looking at the employees and the impact of the healthcare system on communities, anchor institutions. The 4th is working in partnership. And the 5th is advocacy. Advocacy, arguing for change. Now, I think the care system, social care, that's where some of the partnership needs to come. The care system is about improving the conditions in which people live. So I think there's a great deal that the health care system and the health and social care system can do.
Right. We've had a number of questions, and also several really great comments in the chat. And for those of you who put the comments in, that'll be really great to pick those up in the breakout sessions. The first question we had is about the Black Report that one of our participants said she was old enough to be around for, and she said that the Black Report wasn't implemented for a variety of reasons. And what can you see being implemented for little money in our current financial situation?
Well, these things are, I could talk for a long time, I won't, about the whole scientific political issue. The Black Report was incredibly important because it put the whole health inequalities issue on the map. It said there's been a lot of scientific work, and we can summarize that scientific work, and it leads to conclusions about what needs to be done. The fact that it wasn't done doesn't mean that Black was a failure, because Black changed the conversation. And Black led to Atchison, Atchison led to Marmot, to me. And the fact that it wasn't implemented in the short term nationally doesn't mean it was ineffective, because Coventry became a Marmot city. We worked with Tower Hamlets. We're working with Greater Manchester. Gateshead has implemented new policies in the last months based on Marmot principles. We're working with Chester and Merseyside. So a great deal has been happening. There may not have been so much action at national level, but there's been a great deal at regional and city, community level. And in terms of what can be done, I laid out recommendations in 5 areas, 5 of the 6 that were in the 2010 Marmot review. So there's a great deal that can be done practically. I was talking to a third sector organization yesterday, and it can be local government, it can be the healthcare system, it can be third sector organizations, all of vital importance.
Great, right. We have a second question about, people. The questioner says the people with disabilities are said to be hidden victims of COVID-19. Do you think this will raise awareness of disability and health inequalities?
I would like to think, he paused, I'd like to think that COVID-19 has been a wake-up call and a lesson on a number of issues. One has been the Black BAME, Black, Asian and minority ethnic groups. It was possible to preserve the fiction in the UK that we weren't racist. We didn't have structural racism. That was a US problem, or that was a South African problem. It wasn't a British problem. It was possible to preserve that fiction. The COVID-19 has exposed that. It's no longer we're no longer able to preserve that fiction. A second is been the disability issue. We've invisible, neglected people with disability shamefully. And you notice when I talked about intersectionality in the PAHO Commission review, I mentioned disability as one of the categories. And right throughout that report, we talked about the fact that presence of disability makes people especially susceptible to the social determinants of health. So disability is an important category, not just ethnicity, not just socioeconomic position, but disability. And COVID-19 has big effects on people with disability. And that's what I mean by exposing the underlying inequalities in society and amplifying it. And while I'm speaking, a third lesson I hope we can learn is the importance of who keeps society functioning. On Thursday nights, when we went out and clapped for the NHS, did you hear people saying, let's clap for the bankers? Let's clap for the hedge fund managers? Let's clap for the CEOs of the Fortune 100 companies? No, we clapped for the health and social care workers. And some of us were clapping for the drivers and the checkout staff in the supermarkets, the people who kept society functioning. Have we learnt that lesson? I don't know, but I hope we might.
Okay, next question is, for those who break out, I think it's a fascinating one, asks, for those people who are able to break out of poverty, are they ever able to break away from the deprivation they experienced in early years, and especially, or including around issues of adverse childhood experiences?
It's an excellent question. And the answer is yes, to some extent. We know that adverse childhood experiences cast a long shadow, that children who suffered 4 or more ACEs, adverse childhood experiences, are more likely to have mental and physical illness later in life, and they're less likely to succeed socioeconomically and the like. But it's not destiny. So early childhood casts a long shadow, but it's not destiny. It doesn't mean that it's inevitable. I've been listening to conversations I've just bought but haven't yet read, Michael Sandel's new book, The Tyranny of Merit, about the problems with meritocracy, and the idea that he is discussing, and I'll tell you more after I've read the book, but I've heard him describe the book. I heard conversations with him. The idea that he's discussing, he's rather critical of Barack Obama, Bill Clinton in the US, Tony Blair in Britain. He says the problem with the left of center governments is they said, any of you can succeed. It's up to you. Just drag yourself up by your bootstraps and you can make it too. And he said, it's not true. It's not the case that there's a level playing field. And even if it were the case that there was a level playing field, the idea then being that if you don't make it, it's somehow your fault. That if you're a driver, that I've already said, keep society functioning in a pandemic, but you're not a university graduate working in the City of London, there's something wrong with you. And Sandel is very critical of that idea that it's your fault that you didn't get to university. So let's come back to the question. If you had an adverse childhood environment, it makes it much more difficult to succeed later in life. And by succeed, I mean well-being. I don't just mean economically. I mean leading a dignified life, having the capabilities to lead a life you value. And it's much more difficult, but it's not impossible. It's not destiny. We can change the conditions and create the possibility for people to overcome that adverse childhood.
Great. Okay, I think I'm going to pose just one more question. There are a lot of questions in the chat to you about what books have you read and other things, but there is a question on vitamin D and the value and impact of vitamin D. It's a burning question in Tower Hamlets, and there's a question about how much evidence is there that vitamin D relates to people with darker skin color and also onto the COVID-19.
Yeah, I haven't looked at the evidence myself, but I've looked recently at a couple of reviews of the evidence, and I think I may be summarizing it incorrectly, and I'm happy to be put right if I'm saying this incorrectly. But what I took away from those reviews of the evidence was interesting, it's possible, but we're not sure. So it might be that vitamin D would be protective, but the reviews said, well, we're not sure, but it's possible.
Okay, I'm going to give you the last word on anything you want to say arising from all those questions together before we move on to the next section.
Yeah, let me say a word about Tower Hamlets. And why one ought to be hopeful. When we were doing various monitoring reports, and we looked at 2 measures for children. One was the percent of children with a good level of development, age 5, And we looked at it in various ways, but one way we looked at it was children eligible for free school meals and the average. So the poor children and the average. And we also looked at GCSE performance in the same way. In Tower Hamlets, the gap between the poor kids and the average was smaller, much smaller than the national average. There is a London effect. The same is true in Hackney. There is a London effect. And it comes back to the point about growing up in poverty is not destiny. It's possible to make a difference. And in Tower Hamlets, for whatever reason, you've been making a difference. You've been closing the gap in early childhood development and in school performance for the children eligible for free school meals and the average. So I used to say I'm an evidence-based optimist, and I've been criticized for an optimist thinks things are going to get better. So, okay, I'm an evidence-based, hopeful person. I hope things can get better because the evidence shows that you're already doing it in Tower Hamlets. So you have the capabilities to act on the kind of recommendations that I made to make a difference. And if you do it, like with the early child development, I will summarize your data and show them around the world and say, look what they're doing in a poor part of London.
Great. Thank you very much. Okay, if we now move on to the presentation by Raluca, our community intelligence analyst. This is a major piece of work that HealthWatch in Tower Hamlets has been conducting over the last 9 months or so. The work we did through the lockdown is really cutting edge, and we are proud to be able to provide up-to-date insights to the Tower Hamlets Pandemic Committee to enable them to make more robust strategy. It's been a truly collaborative effort. So I'd like to invite Raluca to take us through the headlines of this report, which will be made available on our website as well. So Raluca, it's over to you.
Hi everyone. Hi, my name is Raluca. It's great to be here with you, and I have been extremely impressed with Professor Marmot's presentation now. The work that I am going to show you reflects a lot of these findings, but at a very local level, focused right here in Tower Hamlets. Yeah, Jonathan, could we possibly get the slides up? Okay. Thank you very much. So the story of this project in brief is that in December 2019, we have engaged with local people on what makes our neighborhood a good place to live and how we can support people to live healthier lives locally. And just as we were starting to analyze those results, the COVID-19 crisis hit, and we had to focus on that. And this is when we had another survey and we talked to local people on how they stayed healthy and well during the pandemic. This presentation is, is a result of these two pieces of research put together. Now, a short note about the our approach in the initial project. It was based on something that we call the Tower Hamlets Together I statements. And by I statements, I mean, yeah, can we see the next slide, please? Yeah, so all of these were based on, they were developed by local stakeholders and experts in partnership with local people, and they reflect what the people of Tower Hamlets believe are important things that we can use to measure whether our neighborhoods are good places to live and whether we are achieving good outcomes in our local area. Now, the big question that we have asked people in the initial report was, is your neighborhood, is your local area a good place to live? Let's see how people have answered it. Let's see how people answered. Oh, sorry, my bad. Yeah. Can we go on to the next slide? Yeah, so these are the people who have answered our survey. We try to go for a balanced sample, but obviously the initial engagement was carried out mostly in person in libraries. The COVID-19 engagement was carried out in via telephone and online using mutual support groups. So the demographics are a bit different, but I think we did get a good cross-section of the society. Now, we have asked people, do you think that your local area is a good place to live? Let's see how they answered. So you can see from this presentation that the differences between the most affluent wards and the most deprived wards, between younger people and older people, like they're all quite subtle. And if you were to just look at this graph, you would probably think people's opinions of their neighborhood are not just that different from each other. But as we delve deeper into the data, we realize just how deep social inequalities can work and how they can work at a very subtle level. So if we look at the next slide, we can see that there is some common ground between all the residents. Yeah, people from pretty much all sections of society have said that they want a safer neighborhood, they want less drug dealing, less antisocial behavior. People from all walks of life and social groups have said that access to nature is important for their health and well-being, that they wanted more green spaces, they wanted the green spaces to be cleaner, they wanted less car traffic. There was also very widespread agreement that children's centers and youth clubs are crucial assets for giving young people a good start in life, and that community events and socializing spaces are creating community cohesion. So this is what kind of everybody broadly agrees on, but not everyone experiences their neighborhood the same. We might be living on the same street, but we don't all live the same lives. We found that younger people, those on lower incomes and those in unstable houses, had a much harder time making healthy choices than their more privileged peers. We found that people living in housing association estates felt less safe in this area. We found that people living in the borough's most deprived areas reported poor quality of air. And we also found that BAME people and people with the complex conditions gave less positive feedback on health and social care services than white people and then healthier people. So it is quite shocking to learn that those who had the most need for health and social care services were less happy with them than those who had less need for them. So if we look at the next slide, we can see this illustrated, like the kinds of people who do find their local area a good place to live. They were more likely to live in St. Catherine and Wapping, which is a fairly affluent area of the borough. They were more likely to be homeowners. They were more likely to be in good health. And on the other hand, if we talk to young men, if we talk to people in working class jobs, people with a disability, people who live with housemates in rented housing, they were less likely to think that their local area is a good place to live. So this is a bit of a snapshot on how health inequalities work. Now, if we go further, we can next slide, please. So we've also asked local people whether they feel supported to make healthy choices in their local area. And here we can see how inequalities operate a bit better, because we found that younger people have a harder time than older people to make healthier choices. Those in unstable housing or homeless had a hard time. Those in precarious work or unemployed had a harder time. Interestingly enough, BAME people actually felt more supported to make healthy choices in their lifestyle area, and for that we probably have to thank the civil society and community long-standing initiatives that have been working with them on that. But on the other hand, we found that white non-British people, so people who are of the white other ethnicity, many of whom might be EU immigrants, for example, or from Eastern Europe, were among the group of people who felt the least supported to make healthy lifestyle choices. So this can show us who is already supported and also where the gaps are. Now, moving on to the next slide, we have asked people what helps them live healthier lives in their local area and what hinders them from living healthier lives. So a lot of it was around access to good food, because healthy food shops, markets were the top asset, and fast food shops, unhealthy takeaways were the top hindrance. Gyms, leisure centers were an asset. Air pollution was a hindrance. And then you can also see there the cost of healthy lifestyle. People find that making healthier choices is more expensive than making unhealthy choices. And if we look at the people living in the most deprived areas of the borough, we can see that they are more likely to mention fast food, less likely to mention leisure centers, and they were also the ones who are less satisfied with air quality in their local area. So they are hit the hardest by these inequalities. And if we move on to the next slide, we can see how inequality affects people's access to food, because we ask people whether they can afford healthy ingredients for home cooking. Most people actually did. 50% said that, yeah, it's easy to afford. But when we asked people about whether they can afford to choose healthy food when they eat out or had a takeaway, 37% of those on low income said, no, that's impossible to afford. And only 15% said, easy to afford. And when we think about it also, being able to cook at home is something that is influenced by the wider determinants of poverty, because somebody who works irregular shift works and is out of the house at all times, or who lives in a house share with one poorly equipped kitchen that 10 people are using, will find it much harder to cook at home, which makes it even harder to access healthy food and to make healthy option. Now, moving on to the next slide. Yeah, we have also asked local people how do they maintain a good level of health and well-being during the COVID-19 pandemic. And we can see that they did quite a lot of things. They practiced socially distanced exercise outdoors or exercise in their own homes. Many of them even used all sorts of apps or YouTube videos, tutorial to learn how to exercise at home. Many of them socialize remotely with friends and families. They engage in hobbies, leisure activities. And then we had 8% of people who just told, well, there's not much that I can do. There isn't anything that I'm doing to make myself better during the pandemic. That's completely out of my hands. And those people were more likely to be disabled or in poor health or to have a mental health condition. They were less likely to be working or financially secure, more likely to be digitally excluded. And they were also the people who felt the most socially isolated during the pandemic. Now, another thing that we asked people was, can we see the next slide, please? Yeah. What about digitally excluded? So online tools were crucial for staying well during the COVID-19 pandemic. About a quarter of the people that we spoke to joined a local support groups. More than half used the internet to stay informed about COVID. The internet was used to keep in touch with friends and family. People were using apps for staying physically active, for mental health. But then you have those who are digitally excluded. They had either those who had no internet access or no devices or no IT literacy. And we had a look at who exactly are those people. And we found that they were more likely to be of Black ethnicities, more likely to be older, in poor health, disabled, and less likely to be working or financially secured. So these were the demographics, already kind of underprivileged people who were hit harder by the pandemic and were excluded from the things that everybody else was doing to maintain themselves better during the pandemic. Another thing that we have asked people, if we can see the next slide, please. Hello? Yeah, okay. We asked people whether health and social care services are working for them. So one of the questions that we asked was, regardless of who I am, I can access physical and mental health services. And broadly, people feel that they do. As you can see here, we've got a score of 67 out of 100 as an average on a scale. But are health and social care services really as equal as people think they are? If we see the next slide, we can have a look at it. And we actually found that, yeah, we asked people to give any kind of feedback on any kind of health or social care services that they use. We just asked, how was your experience like? And we found that white British people gave more positive feedback than BAME people. Younger people, those in good mental health, gave more positive feedback than those in poor health, and particularly those suffering from a mental health condition. So like the heavier users of health and social care services gave less positive feedback. And those with a good level of financial stability gave more positive feedback than those who were less financially stable. And COVID-19 has also deeply changed the ways in which we access health and social care services. If we can see the next slide. Yeah, because we did have a conversation with people in December 2019 about whether they would consider using an app to access NHS services. And there was quite a lot of openness about it. The majority of people were interested, but quite few have actually done it. And then in March, June 2020, when we asked local people about accessing services during the pandemic, we found that there was quite a large uptake of services online. People had started to use the NHS 111 website to order repeat prescriptions online. They were filing e-consult forms, having online consultations with their GPs or other professionals. But do you remember from the previous slide, who were the people who had the worst experience, like gave the most negative feedback on services? BAME with long-term conditions, especially mental health conditions, and in poor financial stability. If we just go 2 slides back, the same people, the same demographics who were digitally excluded. So that is a big question to ask ourselves. If we are digitalizing online services and we encourage more and more people to use them online, will this widen the gap between vulnerable and deprived people who are digitally excluded and who are already let down by services, and the more healthier, more affluent people who can go online and sort out their problems quite easily? Or on the contrary, maybe digitalizing services will help streamline them and make them a little bit more efficient and bring them to a point that there is more capacity in the system to offer good focused support to the vulnerable people whom are the most deprived and who would not be able to be part of this streamline. So that is a big question that I would like to leave you to for the breakout groups. Now, if we just go back to the end, all the way, yeah. I want to end this presentation on a very hopeful note and remind you that in our local communities, we have assets that can help us overcome social inequality. Like we have found that faith groups, advice charities, community groups, whether they are formally organized as an NGO or informal, just as a local mutual support groups, can be a lifeline for the most disadvantaged in society. And faith groups, both Christian and Muslims in particular, are important for BAME people. Like here in Tower Hamlets during lockdown, we have found faith groups, charities, and informal community groups working together to tackle food insecurity and to make sure that people who might otherwise have gone hungry could get a hot meal or could get a food parcel. We have found that parks, open spaces are also an important community asset, and we could be using them for socializing and physical activity as much as possible in order to return to the group events and group activities that can bring about community cohesion in the restricted conditions on the pandemic and more as we get out of it. Youth clubs, children's centers were also named by local people as assets in our communities. And there is a lot of scope for intergenerational engagement that will make our community stronger. Like if you remember from the beginning of the presentation, people wanted a safer neighborhood. And when you bring about the discussion about safety, there is quite a lot of distrust between the generations. Younger people said that they feel much less a part of their local community than people who are like middle-aged or older did. On the other hand, older people told us things like, well, when I see young people congregate in my local area, I feel unsafe. So there is scope for intergenerational engagement to bridge this gap. And if we work together between youth clubs, parks and open spaces, faith groups, community groups, we could bring them all together to tackle social inequalities. You're probably asking me how? Well, this is the question that I am putting back to you. How do we make all of this work for everyone? Local organizations of all kinds have had to adapt to the pandemic. In some cases, this means that we're just slogging through and functioning suboptimally until things can get better again. But in others, we have found new and improved ways of working that we can bring this learning with us as we go out of the pandemic. And now this is over to you. And I would like to hear from you on how we can make this work for everyone and especially for the most disadvantaged in our society. Thank you very much.
Okay, thanks, Raluca. That was really great. A lot of detail, a lot of insights there. I'm going to try and squeeze in up to 2 questions if anyone has any. Otherwise, we go directly to the breakout sessions where we address the question that Raluca has brought to us as a challenge. So are there any questions? Just please pop it in the chat.
Okay, 1 second. I'm just scrolling through.
Okay, so the question is, have people's concerns changed over a longer time frame? For example, the 5 or 10 years. Do you have any evidence that goes back that far?
Well, we have had our community insight system since 2016, and what we can do with it is we can see how experience of various health and social care systems has changed between 2016 and now. Now, about the wider what are local people's concern, this was a fairly new and innovative research project. So I would probably have to look back at what other organizations have done during the past 5-10 years and compare with that. But I would be quite excited to see our research framework still being used 5 or 10 years from now in order to compare.
Yeah, I think that's right. We are only comparatively short time into the type of data collecting that we're doing, unless people have data sources or reports from a decade ago that we can look at. But we're building this data, our community insights repository, and we have been able to develop it to such an extent that we have great equalities analyses with it. But getting the longitudinal analyses will take some time. Okay, I'm going to, I see there's lots of great comments in there, and I'm going to urge you to take those on into the breakout sessions. And if there are ones that are not really for the breakout sessions, which some might not be, we will pick them up from this chat and work through them on your behalf. Okay, so John, could I ask us to be zoomed magically to our new breakout sessions? Thanks, everyone.
Yes, Randall. I'm gonna move everyone to the breakout rooms. So see you in a few minutes. Okay, I think we're all back. Randall, you want to make any comments?
Well, thank you all so much for coming. I thought that was an absolutely fabulous event. I hope we can send out a survey monkey or something, because we'd love to hear your feedback on it, and also anything more you want to have put into it. If you have any, I see some people putting in some lovely comments now. If you want to have lovely comments or other comments, you can put them in the chat right now, and we will have that collected in the recording. I'll make another plug for Health Watch. If you want to come along and join us as a volunteer or learn more about what we're doing at some of our events, please do so. I guess we're not having, of course, we're not having face-to-face events presently, but we do a range of consultations and surveys, and we've been doing surveys, training people to do surveys from home over the pandemic period. Do look us up on our website, Health Watch Tower Hamlets, and we'll see you next year with the next annual lecture. And whether we can get a star as big as Sir Michael Marmot, well, that's a challenge indeed, is it not? Okay, thank you.